Everybody, there was some issue in Java.
Good evening, sir. Good evening.
So I welcome.
Namaskar, sir.
Namaskar ji.
So it's my pleasant duty to welcome all of you on this dais. I'm Dr. Pankaj Garg. I'm Secretary of IIP Delhi. And today is a very special day for all of us, the World Anemia Day. And we have chosen, the CIP has chosen this topic to raise awareness about blood anemia. And as Dr. Anupam will be mentioning in more details that what is Anemia Mukt Bharat is a very, very important program for the country. And we are going to discuss a lot of issues related to how to make it possible that every child or every citizen of India becomes anemia free. With these words, I welcome you again. I also welcome Dr. my co-host for today's meeting, Dr. Mukesh Sharma, Joint Secretary, Secretary-elect, and Dr. Anupam Sachdev, who is the coordinator for this program. So I request Dr. Anupam to please welcome and introduce the first speaker and the talk. Over to Dr. Anupam.
Thank you very much, Dr. Pankaj. And, I have been working with Dr. Narendra Arora for the last 2 years on this topic of anemia. And in between, NFHS 5 report came in, which was a little disappointing. And we will talk about it as Dr. Ashok Babu will talk about how and where we are as far as Anemia Mukt Bharat is concerned. Now, although it is actually Iron Deficiency Anemia Day, but for us, iron deficiency and anemia are rather synonymous. But at the same time, we must not forget that nearly 20% of the anemias which occur in our country are non-nutritional anemias also. And in Anemia Mukt Bharat, point number 6 is all about non-nutritional anemias. We have an eminent panel of speakers. Dr. Ashok Babu is Joint Secretary, Ministry of Health and Family Welfare, and he's in charge of the Anemia Mukt Bharat program. Then we have Dr. Narendra Arora, and we all know him as pediatricians, but he's also director of INCLAN and also in charge of INTAGI. And I don't know how many hats he wears. Every time I meet him, I'm surprised with the amount of quantum of work he does and the amount of traveling he does and and guides us. The third speaker is Dr. Kapil Yadav. He is from the Department of Community Medicine in All India Institute of Medical Sciences and is running the Anemia Research Center in All India Institute of Medical Sciences. So what we will do is we will follow the sequence as delineated in the program, and I'll request Dr. Ashok Babu to please share his screen and talk about Anemia Mukt Bharat and where are we as far as this is concerned. Dr. Over to Ashok Babu, sir.
Okay, before Dr. Ashok Babu takes, I just want to welcome Dr. Ashok Babu. He is part of our fraternity. I mean, he gives that unique advantage that being a bureaucrat and policymaker, he is also a doctor. And the other day when I saw one of the presentations, in fact, I instantly asked him, Dr. Saab, mere saath ye share karoge ki nahi? I mean, it was such beautifully prepared, and his understanding of the physiology and the dynamics and plus the public health program, that we are really honored that he is leading the maternal child health program as well as and as part of that the Anemia Mukt Bharat. So I'm sure now with his hands in India can be anemia mukt, because this is a waxing problem for 50 years. So I thought I'll introduce Ashok because he's part of our fraternity and he understands the issue better than any other bureaucrat would understand. Over to Ashok.
I'm in the meeting.
Ashok, please go ahead.
Thanks a lot, Dr. Arora and Indian Academy of Pediatricians. I'm humbled by your words. In fact, when I see the panel of experts aligned here. It's my experience counts very little when compared to all of you. Now, coming to my topic that is given to me, what has been done and government's priorities and also the challenges ahead. If at all we look at the anemia, the simple problem that looks so mundane that it is just the oxygen carrying capacity being less in the body. So it reflects as multiple problems in a person. Of course, when I see it as a public health problem, when I was going through the literature, it says any country that is having more than 40%. I was browsing through different articles. India is painted red in that. One of the reasons is any country that is having more than 40%, they consider it is suffering quite severe. When uh, when we see the comparisons between NFHS 4 and NFHS 5, the things are not so rosy, but things are not that much gloomy also as far as our efforts are concerned. Coming to the topic that is given to me, the first part is what we have done so far, and what are the second part, what are the challenges ahead. And once Dr. Arora happened to meet me in my chamber, there are a couple of discussions within the government what needs to be done at this particular juncture. I was discussing with him about this anemia problem and what can be done, what are the issues, etc. It gives this kind of platform gives me the opportunity to share a couple of thoughts. Coming to what has been done, when uh, when multiple efforts which were already being done, all of you know there are quite good efforts from the government. National Iron Plus for Iron Plus initiative, Anemia Mukt Bharat. Not only this, there are a couple of other efforts which are related to anemia, like National Food Security Act, food fortification, etc. When they are simultaneously running, the specific effort of the government, that is Anemia Mukt Bharat, it has started 4 years ago. I see as a person who has already done a master's in public health, the first and foremost thing that when we try to attempt a public health problem is our public health posture, our willingness, our alignment, pulling out resources, the plans, the monitoring systems, the way we execute, the way we keep our ways to correct ourselves. These are the things that also count in our entire fight. If you see the Anemia Mukt Bharat, the strategy, it's like we try to holistically cover. In fact, after a lot of consultations, it is being made. Uh, if you see the efforts of the government, the first and foremost is that we try to understand the problem by having a well accepted survey. Whatever is the procedure that we do, but that is being done more or less regular intervals these days, and we get to know the quantum of the problem. That is the first effort government is doing as a step to understand the problem and try to take the fight by holding its horns. When I say that the things are not so rosy from NFHS 4 to NFHS 5, good that things have come into the picture. We understand anemia, our understanding to know it, one figure I would like to state at this moment. The adolescent anemia, if you see, even in NFHS 5, it is almost 52%. And if you see the anemia in pregnant women, it is 58%. When 15 to 19 group is having almost 52%, nothing new when hemodilution, etc. sets in a pregnant woman, it raising up from 52 to 58%. Then what is happening in the adolescents? What is happening in the pregnant women? What can be done? After estimating the problem, we try to cover, at least in the Anaemia Mukta Bharat program, all the age cohorts that require this kind of efforts, children, adolescents, pregnant women, women in reproductive age group, and everything. We try to cover them. Then individually, if you see, in fact, just to quote, before joining IAS, I was a PhD doctor. The problem of anemia, which was there, the way we try to estimate it. At that time, I found it quite raw. Maybe I call it quite rude. You try to take a prick, you try to put it in a either you try to have a color strip where you try to compare, or you try to have some blood drop and try to collect it, estimate it, taking back to the lab, etc. If you see the current approach, government doesn't mind in spending the money in the National Health Mission PAPs when we see it. The first and foremost thing in the nutrition that comes is how many proposals a state has given to buy the digital hemoglobinometers. And we don't hesitate, whatever the state proposes, first we say you the first plank in the Anemia Mukt Bharat is diagnosis. You try to go in a digital manner and assess your problem and try to work upon it. This is an approach of the government which is not hesitating to go to each and every individual in a digital manner. Then we have a couple of varieties of tablets. We go in a color combination and dosages. Each age group it varies. Pink, red, syrup. We run it, and I'll come to the other parts of the challenges which we see in the program. The after diagnosis, counseling, etc., we keep Asha exclusively on this duty of like monitoring her and try to improve. In a large scale of almost 3 crore cohort, try to try to try to put them on the right treatment is our effort. We try to first deal with iron folic acid. We all know there are a couple of issues. As an individual and one person trying to have this 188 duration of treatment, then we have the iron sucrose treatment and also followed by the blood transfusion. We have a JSSK program. We cover it free of cost. Nobody needs to hesitate to have treatment, whatever that is being prescribed. All these levels, IFA tablets, iron sucrose, or blood transfusion. So, I think hope somebody is playing music. Sorry. Uh, maybe yeah. Uh, is it too loud? The music is disturbing, I think.
No, sir. We are able to listen to you properly.
Yeah. After the diagnosis and treatment, then this point of talking. Believe me, whenever I attended, maybe in my service tenure, I might have attended maybe hundreds of VHNDs in designing a program or trying to do whatever is the plan. Anemia is one of the first and foremost thing every ASHA and ANM tries to work upon. She talks about it. She checks the eyes and tongue, whether it is good or pallor or anything. This anemia is being prioritized at the bottommost level that is possible, right from diagnosis, counseling, treatment, etc. Then, having said all these things, having government prioritized, allocating certain resources, people are doing the job. What is happening? Why these things are not improving further? At this point of time, then I'm talking like an academician now. Now, we have a couple of issues. We are trying to address them. In fact, Mr. Yadav is there in one of the groups that has made recommendations in EACPM, Academic Advisory Council of Prime Minister, etc. We were working upon this problem. Will the sample collection from the capillary, now I'm coming to the challenges, from the capillary to intravenous sample, will it make that much impact, or will it make that much difference at the population level? When we try to do this question, we have the ready-made data, at least up to the adolescents, that is available from the CNNS survey, where they studied in the children, the anemia levels, and also we have NFHS 5. Both are not much dated, not much gap is there in the both. It is around 2016 to 18 is CNNS, intravenous sample, and NFHS 5 is 2019 to 21, that is a capillary blood sample. Because both the groups cover adolescent population, when you see the figures, the adolescent anemia in CNNS through intravenous sample is 17%. But if you go to the NFHS, same cohort after 2 years, it becomes 31. So without making any comments, can it make almost the sampling methodology, can it make almost 100% difference? The question is, I need to say, yes, this is what is the evidence available that is showing. Then what makes a capillary sample to show the anemia to that extent that is almost 80 to 90% higher? Then I was going through various articles. In fact, some of the academicians in India I was discussing, I might have read around 15-20 articles on this. Like when you take a prick from the finger, the capillary, the ability of a disc-shaped ball, what I call an erythrocyte, to roll itself and squeeze into one particular place, which is very less in volume, to adjust into the volume, lumen and go, is tough. Then I was comparing with some studies of a dam. In the dam also, this is the same property of the stones to squeeze into a narrow channel and impact the dam. This kind of studies happen. This kind of fluid dynamics. When I say studies, things impact a capillary prick. The temperature, the depth of the prick, the ability of the testing person to press it. Probably you and me know this skin and this stratified skin, both are different, and take a bath, I can see this skin absorbing more water and getting wrinkled. Then if I press it after the prick, what is the amount of fluid I am pumping into the sample to dilute it? So it is not only the disc-shaped ball to roll into a capillary narrow lumen, the depth you give, the amount you squeeze, the temperature you are checking in, 100 things that attempt. So we had a thought, in fact, at the highest level, this discussion has happened. Dr. Kapil Yadav was also there in one of the committees that finally recommended we should move away from this system. Then immediate question comes, then if the problem is 100% less in India, the anemia, obviously that question I do not want to answer. Yes, there are people suffering. For a public health problem, to delineate who are suffering really, I'm not putting them artificially in the bracket that you are suffering, that's why you need these IFA tablets, whether you have anemia or not, you suffer gastritis. That should not be the approach. If a person is really requiring it, he needs to be given. So we at the highest level of Honorable Minister Health, we had a discussion. It took almost 6 months, repeated meetings, various documents, feedbacks, etc. Then we thought this time we should give to ICMR. We'll request our own ministry, that is an NFHS survey is done by our own department, and we thought let ICMR do the survey. Let ICMR do the survey and give us the result. ICMR said it has the preference only for intravenous, and it will do only intravenous, which is the gold standard. It gives the problem in a realistic manner. What is the prevalence of anemia in 1 or 2 years? Then the next challenge. The problem with anemia estimation is it is not the threshold that is being fixed. When I say what is the right heart rate for me, I tell 60 to 100. If I am an athlete, if I am running regularly, I'll have straight bradycardia. I will run around 60 or 70, or some other reasons I may have 70 or 80. So, but in anemia, there is a problem. You give a fixed number. Less than 7, severe anemia. Less than 11, in that particular category, severe anemia. When you give a particular number and put it as, it is not the range, it is a number. Below which you are this, above which you are this. That kind of thing, what happens when you make a population study, there are quite good number of variations in a population. based on the way they live. Somebody may be living on the hills, somebody may be living on the plains, and somebody may have too much muscle mass, somebody may be having less muscle mass, less work. Let us understand one particular thing. Two important things. One is glucose, other is hemoglobin. I mean to say the oxygen. They both mix up and give energy. Say, assuming I don't have muscle mass at all, I don't require that much muscle, that much oxygen carrying capacity at all, but still you are aspire me to reach that particular level because there is no range to accommodate everybody, but you have given a fixed line. Whoever is not reaching the range, you say you are anemic. I was reading some literature about it. These anemia thresholds were fixed in 1967. These anemia thresholds were fixed on 4 studies. Out of the 2 are published studies, 2 are unpublished studies. Number 3, these studies are made on all white sample, all European samples. That means the threshold with which we have fixed is a fixed number. It is quite dated. It is made quite long back, and it is not in ranges. That means this threshold has certain issues. Then we wrote to WHO. WHO is doing the study on the same topic from 2017. They said, yes, some study is happening. We'll try to conclude the study and we will give you population level thresholds within 1 year. That's what WHO responded me. So when I see the challenges, these 2 challenges I am just placing. Now, number 1, the way we test the sample, the way we collect it and test it. Number 2, the way we fix threshold in India. I was just seeing randomly what is happening in Sri Lanka. Sri Lanka, I was reading one article. It says they're doing only intravenous sample. They don't go for capillary. At the population level, we try to justify capillary method for many reasons. One, it is easy. People may not come for intravenous sample. When this discussion was happening, honorable minister sir said one thing. क्यों नहीं आते हैं लोग? कैपिलरी के लिए आएंगे बोलते हैं, इंट्रावेनस के लिए कंप्लेंट्स कम है बोलते हैं. क्यों? आप टेस्ट करके उसको बोल दीजिए फ्री ऑफ कॉस्ट, आपको एक रिपोर्ट भेज देंगे आपका मोबाइल पे. कोई भी ब्लड टेस्ट अपना फ्रीली करना चाहते हैं पता करने के लिए. Will it not improve compliance if you communicate in the same day or next day the result? Like that, minister sir was if it is good, if it is gold standard, we'll go for gold standard. So ultimately, after elaborate discussions, we thought this time NFHS will not do capillary study, and we'll request our other department, that is Department of Health Research, to do through intravenous sample the hemoglobin estimation. Thus, we'll get to know the prevalence of anemia. After these 2 issues, the third challenge is our attempt to deal with anemia in a public health problem. Having understood 50% only is the nutritional anemia, other things are like you may have worm infestations, etc., contributing it, genetic factors contributing to it. In a vast scale like India, to segregate who is this 50%, who is the other 50% is one of the challenges we encounter. The other 50%, there are a couple of efforts. Recently, government is going to announce the problem for sickle cell anemia, etc., how to deal with it in the particular communities. We have for worm infestations, etc., deworming program, National Deworming Day we conduct. We are trying that, but this is one of the challenges. And the fourth challenge I could see is the close relation between malnutrition and anemia. When the protein synthesis is not so good, that's why it is leading to whatever is kwashiorkor, marasmus, whichever type of malnutrition. When the protein synthesis is affected, we cannot expect the heme or globin synthesis to be better than normal other protein synthesis. When the malnutrition is continuing to the bigger extent, we see this problem is also closely linked to it. We need to holistically address this problem. Just last week, the Niti Aayog, some of the members were there. There's a long discussion how to address this problem, and we are thinking, is there any other way we can deal with this problem jointly together? The fifth challenge I could see is the problem of iron folic acid. The iron folic acid, I could see there was a list in one of the WHO's document, which country gives 60, the elemental iron of 60, some give 40. I think we used to give much more than 60. I think it was around 100 or something couple of years before. Our inability to bring at low cost one elemental iron or a combination, let it be sucrose, let it, I have seen maltose combinations, other combinations. The way we make this medication, our ability to convince a pregnant woman that it has the least complications, I see that is a big challenge. And the compliance issue, not taking it, and that's why our ability to control nutrition anemia is one issue. Our ability to accept Ayush remedies is one more issue. I was there in the Department of Women and Child Development, and we are before becoming Joint Secretary in Health. They had a program in Karnataka. They studied in 2 or 3 districts somewhere around Davangere about Draksha Valaya. They said, why don't you see 2 effects of the iron in this Draksha Valaya? One, it gives iron. Second thing is its absorption. What we call in medical terms transferrin, it takes, it attaches, it goes to the other side and releases. Why don't you see the absorption effects of iron? You just check, our inability to work on absorption is one more challenge. The first and foremost thing that prevents the absorption is your tea, the coffee and tea. I was reading some other literature before this. Some literature says it can stop if you take simultaneously or within 2 hours after food, tea, it can inhibit up to 70%. Then when Draksha Valaya, the Ayurvedic solutions, are able to give the result because it is natural or it may have more ability for transferring across the alimentary canal, then we say the Ayush medication is not fitting into the modern medication system. I mean to say, okay, this is Draksha Valaya. I tested it. There are some impurities. We are used to preparation of tablets, medication in a classical manner, whatever is required, like paracetamol, acetaminophen, itna, ohi chemical, itna hona hai. If you want to mix this thing, or if you want to add any color to it, or any coated around it, this is the chemical. We are tuned to the puristic science. But Draksha Valaya cannot fit into this puristic science. Maybe after preparation, it may have some elements, some impurities, something. Then we say, because it is not refined, we will not use it. Then our alternatives, if you see, they continue to irritate the stomach, they cause gastritis, the abdominal pain, constipation, then we don't have answer. My fifth challenge, if I see what are the challenges ahead, that is the topic given to me, our inability to take one medication to the pregnant women or adults in goal and say that it has no complications or almost nil complications, please continue to use it. When NFHS data comes about consumption, we see both distribution and consumption. Let me agree, frankly, there is a lot of difference between them. People have issues in using it, few tolerate it, few are unable to tolerate it. Coming to the last challenge, the science and research, when you see, when I see it, I did my MPH in Johns Hopkins. One of my capstone project is how Johns Hopkins is not contributing much to the public health. The research and science is so set in. What is being researched, what is being piloted, what is being taken into the system has to be commercially viable. Approximately, there is a research, classical research in UK about heart disease. What is the research? How much money has gone, and how much money is actually reaching the poor? 7%. If somebody spends £100, they studied 15 years research funding and what is available to the poor. Approximately 7%. If you spend £100, what is reaching the poor is only 7. Then rest of the 93, that is going to those commercially viable products. Otherwise, it cannot sustain. The research is set in such a way that only that is commercially viable is picked up and continues. But at this moment, we need to do the research aspect, especially for the problems of India, like malnutrition or anemia, or for that example, tuberculosis. Many things that is being classically seen have been not giving results over the years. This fact we need to agree. Like tuberculosis, it's been there from Rigveda times, from 5000 BC. There have been many medicines, many researches, many things that have happened, but still we need to see. Recently, I see some light in that. Can anybody, any TB resistant case without autotoxicity till 3-4 years back, can anybody say you take this tablet, you will not get autotoxicity in a TB resistant case? No. Is it the till 2015 or 16? This is the case. Is the research sufficient enough? Is the tuberculosis is the disease of rich or poor? Is it our inability till 2015 or 16? There are a few new drugs we have been using, but we, just like in anemia, I cannot say to the pregnant woman with least complications, you take this drug. No. There are some discussions on FCM, etc., pros, cons. In fact, 2 days back also it is discussed. So my last, I can call it, my appeal is about the research. There's a lot to do for the poor, lot to do, especially when this public health problem is that much huge. So with this, I'll try to close it. Government has been on the job. Of course, there are a lot of opportunities to improve further. There are certain challenges. With the help of all the fraternity like you, technical experts, I think we can surmount this problem. Thank you.
Thank you, Dr. Ashok Babu. It was a pleasure to listen to you deep insight into the Anemia Mukt Bharat. And we are proud that you are leading from front to make the Bharat Anemia Mukt. And we as a fraternity and fraternity members and as a member of Indian Academy of Pediatrics are also constantly, it is our endeavor to help the government in its national programs and programs like this Anemia Mukt Bharat. And the IAP is determined to make this happen along with the government. And it was really nice to listen to you. And thank you very much for sparing your valuable time. I know that you must be very busy, and to taking out time from your busy schedule to give us deep insight into the program and its what challenges we have is very important for us to know. Thank you so much. I would ask Dr. Anupam Sachdev sir to kindly say a few words and invite our next speaker, Dr. Kapil.
Thank you very much, Mukesh. That was a brilliant presentation by Dr. Ashok Babu, and you know, my concern has been that probably one of the reasons that we are not able to reach out to the people and they are not taking their medication properly is because we have yet not got into mission mode, as they say, with anemia prophylaxis program. And I think we should think of going into mission mode as far as this program is concerned, because it is not just anemia, it is cognition of the children also which is affected by anemia. And if you get a drop of 5 to 10 IQ points, 5 points or so, it makes a tremendous difference in the incidence of IQ, low IQ in the country. So it's very, very important that we do that. And interestingly, in the last 2 years, we have done a study on school-going adolescent children in Delhi, and we included 2 government schools and 2 private schools. To our surprise, well, we did give an explanation for that, but to our surprise, the private schools had a higher incidence of anemia. Despite having good nutritional intake, they still had a higher incidence of anemia in amongst them as compared to the government schools. Also, the usual deworming and giving of iron folic acid tablets was not being followed in the private schools also. I think this is also important that we consider. Even the private schools, if we are giving the government, if it is giving iron and folic acid and deworming, private schools are also a part and parcel of our system, and they need to be brought into the cover or under the umbrella of this program. So I think now with these words, we don't seem to be having Dr. Kapil, and he was trying to get onto this thing, but he's not been able to get onto the program. What I can do is, I can start with my presentation and then move on from there. Will that be all right, sir?
हाँ जी सर, that is absolutely fine. आप ऐसे ही करिए, अपनी presentation शुरू करा लीजिए. हाँ जी.
मेरे को स्क्रीन शेयरिंग का दे दीजिए, राइट?
राइट है सर, इसमें सबको है.
चलो ठीक है.
हाँ जी सर.
Well, give me a second. Okay. What I'm going to be dealing is non-nutritional causes of anemia in our country. And you'll be surprised to know that, non-nutritional causes of anemia can be divided into blood loss, which may be postmortem hemorrhage. It may be heavy menstrual bleeding in adolescent girls. It may be irregular bleeding, GI blood loss, urinary blood loss, and increased hemolysis, which may be due to infections like malaria, hemoglobin disorders like sickle cell disease, thalassemia, enzymopathies like G6PD deficiency, which is not that uncommon in our country, and immune-mediated hypersplenism. Microcytic can also, deficient erythropoiesis can also be due to anemia of inflammation, thalassemias. And don't forget that anemia of inflammation and iron deficiency anemia can go hand in hand. And of course, you have the bone marrow failure syndromes, which is not that common, although we see it very often, but it's not that common. Okay, word about thalassemia, because we are in north of the country and we need to know what is it. In central India, it is about 1.1 and 3.4%, but overall in our country, the incidence is about 4 to 5%. So if it is 4 to 5% prevalence in India of thalassemia trait, it means that nearly around 6 crore population is actually having thalassemia trait, and they're all going to be mildly anemic. So that is a huge number which is there. And it is also prevalent in Eastern India because of E-beta, E thalassemia or E-beta thalassemia also. Now, basically in beta thalassemia, there is a paucity of production of beta chains, which leads to accumulation of alpha chains, and that causes, gets precipitated, causes damage to the cellular membrane, leads to dyserythropoiesis and hemolysis. And that's the basic physiology of thalassemia. So you have ineffective erythropoiesis and you have RBC hemolysis due to oxidative stress. Now, thalassemia can vary from thalassemia trait to non-transfusion dependent thalassemia onwards to beta thalassemia intermedia and etc., and the transfusion dependent thalassemia, which is the severest form of thalassemia. Now, basically, both the conditions, TDT and transfusion.
Your slides are not moving.
They're not moving here. They are moving here.
And I don't know whether it is moving for the others. It is.
Yes, sir, it is not moving, sir. Dr. Anupam, what you can do is you can just select the slide from the left panel. Then it will move. Now you select it from the left panel. Where you're seeing the small slides.
There are no small slides. See.
सर तो लेफ्ट साइड में जो पैनल है ना इसमें इसको सेलेक्ट करो अपने जहां जो स्लाइड दिखानी है फिर वो मूव कर जाएगा.
अच्छा मैं देखता हूँ कोशिश करता हूँ.
हाँ अब मूव करनी है ना सर बस जो भी स्लाइड दिखानी है उधर से मूव कर लो.
चलो ठीक है.
Right.
So basically inheritance of thalassemias or sickle cell is all autosomal recessive. So you need to have both parents or both the mother and the father being positive for thalassemia trait, and then only you have a 25% chance in each pregnancy of having a thalassemia major, 50% chance of having a thalassemia trait, and 25% chance of it being a normal child. Now, basically, you need regular transfusions and you need to maintain the hemoglobin above 9.5 to 10 grams per deciliter. Adding to the problem is the problem of transfusion transmitted diseases, and of course, the burden of iron, which leads to accumulation of iron in the body, leads to damage to various organ systems of the body. And this is how the various organ systems are damaged. Now we have pretty good medication for removal of iron from the body, and under the NHM, we are having good support for thalassemia patients. Although I wish, again, as said, that those who are taking their transfusions and their medications in the private sector, they also are a part of the country's children, and they also need to be supported from the NHM with the help of support from the government for chelation therapy, etc. Now, a word about sickle cell disease. Dr. Ashok Babu did allude to it, and I have been a part and parcel of the sickle cell disease project under the Ministry of Tribal Affairs and Ministry of Health. And we are embarking on a huge and ambitious program to screen and find out the, screen for sickle cell trait in the tribal and scheduled populations, to the extent that we are thinking of screening about 4 crore population in the next 3 years with a huge budget of nearly 2,000 crores. And we've already settled down on the tests which we are going to do, which is the point of care test. The prevalence is the maximum in Jharkhand, Chhattisgarh, Chota Nagpur, Gujarat, parts of Odisha, Telangana, and down south in the Nilgiri hills of Tamil Nadu. a huge population of nearly 15 to 20 crores, which is suffering, which needs to be evaluated. And the basic problem is not only sludging because of sickle cell disease, but now we know that it is inflammation of the endothelium which causes the problem in sickle cell disease. Again, as said, that it is also an autosomal recessive disorder with a 25% chance in each pregnancy of having a sickle cell patient being born, 50% chances of a sickle cell trait being born, and 25% of a normal child being born in each pregnancy. The diagnosis is by HPLC, and you can have sickle beta, also combination and interaction of beta with sickle, which behaves like sickle and like thalassemia intermedia or non-transfusion dependent thalassemias at times. It requires regular transfusions in these patients. Rapid testing is what we have been talking about, and that is hemotype SC or sickle scan can be used. These are slide tests, slide-based tests, in which you put a drop, just like in a pregnancy testing kit. You put a drop of urine here, you put a drop of blood, and you can come to know whether the patient is sickle with trait or a full-fledged sickle, and make the diagnosis. And the interesting thing is that on the slide, we have now been able to put a QR code, and we can scan the QR code on the Aadhaar card and scan the QR code on the slide and upload it immediately at the time of testing. Okay. The problems can be many. It can be in the form of acute pain syndrome, chest syndrome, priapism, acute splenic, sequestration. You can have chronic pain, cerebrovascular disease, pulmonary hypertension, leg ulcers, avascular necrosis, retinopathy, renal failure. We have a huge population of sicklers who are coming to us with all these conditions, and so on and so forth. The other drug which is used is hydroxyurea, which is an anti-metabolite, and it helps in increasing the HbF level. And it has now been shown that even in babies, if you start using it, it prevents the babies from going into dactylitis and other complications. In addition, you need to give folic acid, and also you need to give penicillin prophylaxis in these children. And in fact, it is said that when the patient is diagnosed at birth, the penicillin prophylaxis should start immediately, because that prevents pneumococcal infection, which occurs because of hyposplenic function in the sicklers. And we can also, in the sickle cell program, through the Indradhanush, they are planning to give pneumococcal vaccine, conjugate vaccine to all sicklers, and that is being built into the Indradhanush program also. Although Indradhanush program is age limited, but here we've been talking of adding adults also to prevent pneumococcal disease in these patients. There are multiple indications for transfusion in a sickler. It can be to reduce the cerebrovascular accidents. It can be to reduce the priapism, pulmonary syndrome, pain. It can also be to reduce the other complications, but basically need to have attached them to the integrated hemophilia and hemoglobinopathy centers for their good transfusion therapy. Other conditions, hereditary spherocytosis, not that common, but it is seen, and Dr. Pankaj, who's a neonatologist, would vouch for it, that quite a few patients of neonatal hyperbilirubinemia are due to spherocytosis. The symptoms are, you can have neonatal, jaundice, you can have splenomegaly, you can have jaundice, indirect hyperbilirubinemia in the later life, and also you can have low hemoglobin. Although splenectomy may cure them of the, will not cure the disease, but ameliorate the symptoms of the disease. But we try and avoid it unless and until we are pushed into a corner. Malaria, again, has grown in our country, and although it's not as common now as it used to be when we were children, because we used to see a lot of malaria when we were kids. But the symptoms, nobody has to tell the pediatricians what are the symptoms: fever, fatigue, pain, muscular, back pain. You can have chills, sweating, you can have dry cough, spleen may enlarge, you may have nausea and vomiting, and all the problems. And of course, the treatment is well prescribed and well known to everybody in the form of chloroquine, primaquine, and other drugs which are now available. Then anemia of chronic disease. You know, as Dr. Ashok Babu mentioned, that in the country, the malnutrition, decreased immunity, anemia, and chronic diseases like infections, etc., run hand in hand, and they contribute to each other in a big way. So we need to look at them also as a cause, and we need to evaluate these patients for severe in this thing. Of course, you can have anemia of chronic disease because of autoimmune disorders, malignancy, which are not that common, but infections per se are very, very common cause of anemia of chronic disease. So, friends, all that I can say is that in our country, we are crying out for help as far as anemia is concerned, and we need to get our act together. It is more than 4 decades, and we have not really made any dent in the situation, and we need to act together and hold each other's hands to sort of kill this disease and, as I say, take care of our chronic iron deficiency anemia problem. Thank you.
Thank you, Dr. Anupam, sir, for addressing one of the main concerns of the Anemia Mukt Bharat, that is the addressing, we have to address the non-nutritional causes of anemia, and these account for almost 20% of the total cases of anemia. And Anemia Mukt Bharat is only possible when we are able to contain this particular segment of anemias also. So thank you so much for your words of wisdom. So are we ready for Dr. Kapil's?
I think we'll move on to Dr. Arora. He'll cover a part of the presentation of Dr. Kapil. And may I request Professor N.K. Arora to please start his talk and bring out the finer nuances of, how to manage and what are the technicalities in Anemia Mukt Bharat. Sir.
So, thank you very much. I will be making a brief presentation. I hope you are able to see my slides. Can you?
Yes, sir.
Okay. पूरे screen पे आ गया ये? Is it on the?
Yes, sir, it is visible.
Yeah. So thank you very much for this opportunity, Delhi IAP and Anupam, for giving me the opportunity. And for last 1.5 years, we are working with the government and Niti Aayog to see that how we can work in a direction so that the needle on anemia starts moving. And I'm sure all of us are aware that Anemia Mukt Bharat is a very 360-degree approach towards this public health problem. And here I must say that anemia is world's biggest public health problem. It is not only India's problem, but globally, this is an issue of immense public health relevance. And I will not go into details. Dr. Ashok Babu has already given a glimpse of the way the program is undertaken. just to look at the the issue, the program, and I would like to um, say that it is a life cycle approach that children 6 months to 59 months, children 5 years to 9 years, adolescents 10 to 19 years, and then women of reproductive age, that is goes up to 45 years, and pregnant women. So it takes care of all the age groups up to pregnancy. Available stock, that means supplies in the system, is a very important dimension, and these form the 6 key performance indicators. And it is not, I know the audience is the clinicians, but the question is that as a clinician also, when I am looking at my population, be it pediatrics, now in fact adolescent age groups also comes within our purview, but the important thing is not to forget their mothers, whether they are pregnant or non-pregnant. So I think as pediatrician, we can address all the key targets for Anemia Mukt Bharat. And we know that they are the most vulnerable. They have the highest prevalence of the burden of the anemia. Now, just to give you what has been the coverage under of iron folic acid under various age categories. The first one is pregnant women, and it has really highest, and it seems pretty well, 92% in last 1 year, which is very encouraging. But as we move forward, then we'll have to see what else is happening. The important point is that beyond pregnant women, the lactating women, it comes down to almost 50%. And for children, it is 20 to 30%. So it clearly shows that depending on the program focus, the coverage is inadequate, less than desirable in our children. And similarly, lactating women and women of reproductive age group are also not well covered. Now, this is something which is important between NFHS 4 and NFHS 5. Dr. Babu has told us that the anemia, wherever anemia is more than 40%, it is considered a major problem, public health problem, and we need to take care of that. And what we are seeing is that consumption of iron folic acid has improved for pregnant women by 14%, but the prevalence of anemia has decreased across the other age groups, whether it is 6 to 15 months, non-pregnant women of reproductive age, pregnant women, and all women of combined of pregnant and non-pregnant. And then men are also, we have forgotten, it is not a focus, but here also, and there is a worsening over NFHS 4 to NFHS 5. This is to be seen in the context that the measurement has been with capillary, which Dr. Babu highlighted. And as I understand, ICMR is now going to do a nationwide survey on anemia using intravenous, so that that confusion, whether what is the, and it will also tell us what is the gap between intravenous versus the capillary sampling. One important point is, just look at this. The IFA coverage has increased over the years. But anemia in pregnant women has not improved. If at all, it is either, we will say, stationary, or it is on the lower side, but there is no improvement despite increasing coverage. So one has to start looking at things which is beyond just IFA. And I think that is very important, and a point highlighted both by Dr. Babu and Dr. Anupam, that non-nutritional components have also to be seen. Now, this is a busy slide. I don't intend, you don't need to look at the whole readout, but I'll just try to highlight that IFA coverage, a desirable coverage or a reasonable coverage above 60% is only in 4 states of the country. Children for 5 to 9, only 4 states. For adolescents, it is only 6 states. Mind you, we have 36 states. And many of the target population is not well covered in the dashboard, or they are being not monitored. For example, men 20 to 49 years. Similarly, men and women more than 50 years. And recent data from a couple of studies, and including a cohort study in 25,000 population across 5 sites, 5,000 each into 5 sites. The anemia actually starts increasing in men and women above 50 years. So these are at the moment not covered, and they need to be covered as part of. Because many times we assume that men, particularly the adults, and then older men and women both, they are also having anemia. They may be having around 20% prevalence at the moment. But beyond 50 years, again, it starts rising. So population saturation, or that means coverage, relatively better in pregnant women, but still anemia persists. And there have been some fragmented efforts to reach children and adolescents, the population which we as pediatricians look after. We have not been able to reach. And so basically it means that there are insufficient touch points for beneficiaries, and there are other issues of how to reach up this population. Adult men and older men and women, I already talked about. And several of the states have really not fully operationalized or kicked off with the Anemia Mukt Bharat. There was a lot of emphasis about measurement of hemoglobin. And as part of Anemia Mukt Bharat, here the measurement is for clinical purpose, not estimating the burden. So there are 2 issues. One has to very clearly understand that NFHS is estimating the burden. But when I'm in the field, what do I do to decide if a person is anemic? And if somebody is anemic, a treatment has to be given. So now program for the first time has come up in a big way that there are digital hemoglobinometers to be available as part of the program. These are both like pulse oximeter, this one, or HemoQ and true hemoglobin. These are capillary methods. So both are being evaluated, both types, but at the moment it is mostly capillary. But from a treatment point of view, it is a kind of a very pragmatic and approach. The problem is that these the whole program approach is to test and treat. So anybody and everybody who is tested, and if they find the person is anemic or the child is anemic, person has to be treated, but testing. And these are point of care testing. But the issues is that these lot of places, the instruments are not available. There are issues of procurement. Another important point is devices mainly available for testing pregnant women. Again, this is program focus. The program has to widen its focus so that children, we are able to focus on them. The problem in children is as much, if not more, in in children also, and they need to. The question is, where do I test them? Should I test them in well baby clinic? Should I test them in immunization clinics? But that will only cover up to 2 years. What about children beyond 2 years when they finish their immunization, or 5 to 9 years, 10 to 15 years? Should this be made part of the school health programs? Because there are no health and wellness visits in that age group. So there are a lot of these challenges, and that's why you see the coverage is 20 to 30% in this population. And then maintenance of the equipment, calibration, and large-scale validation of non-invasive immunoglometers is also desirable. There are a lot of now equipments available, but even for clinical practice. So we know that today pulse oximeter is available for 50 rupees. It is a reasonably valid tool, but when you use the bigger pulse oximeters, there may be differences. So similarly, these also have differences, but as a screening device, as a decision-making point, these are excellent tools to move forward. Supply chain or availability of products is another issue in the program, whether it is issues related to forecasting, how much I require, how to procure that at the right time, inventory management, distribution of the product, and then its availability at the most outreach point in terms of whether it is ANC clinic, whether it is health and wellness centers, sub-centers, availability is important. And so this requires now IT solutions so that there is one is able to monitor them and there is accountability fixed in. Some states have come up with very good examples how to ensure that the supplies are available at all times at all delivery points. But there are some of these challenges which need to be taken care of across the country. Behavior issue, again, Dr. Babu had raised this issue about creating awareness and using various channels. In fact, I really appreciate his point that why can't we use some of the traditional Indian Ayurvedic products, which may be more acceptable culturally. They may not be only acceptable culturally, but biologically more efficient. Because if the absorption is better, vis-a-vis IFA tablets, which have huge compliance issues, which are acceptance. And I'm sure in the audience, the women who have been pregnant and the consuming of iron, particularly during pregnancy, is not an easy task, and most of the women have difficulty. So that's a suggestion which needs to be operationalized or implemented, and I'm sure they will be takers on that. And the other important point about the behavior change communication is in terms of understanding of the community of the food diversification. Now, this is such an important component that just a single strategy of a single channel of supplementation is not going to take away. Multiple channels of enhancing iron consumption and absorption are required. And for this, a social mobilization program is particularly important. Then this whole issue of awareness about food fortification and fortified food. Fortunately, and I think as a leadership exercise, the government has taken a view, has initiated and launched fortified rice, but a widespread awareness has to be created on this issue. Non-nutritional anemia, I will not dwell too much on it. This is at the moment not being reported all over. This is a huge problem. I heard Dr. Babu saying 50% and Anupam Sachdev saying 20%. The issue is it will be variable according to the area and context. In tribal areas, a certain type of non-nutritional anemias may be present. In other areas, the other type of non-nutritional anemias like infection, inflammation, and a mixture of both. So a systematic study also is required. And when anything is more than 10% or 20%, I think unless a focus is given, it will be missing out non-nutritional component. Very important point is, for example, thalassemia. It is a non-nutritional anemia, but we know that a lot of trait carriers or thalassemia minor, they will also be nutritionally deficient. Iron, folic acid deficiency may be there even in them, and it is, in fact, 60 to 70% of them have this issue. So these are some of the sticky points which need to be taken care of, that we manage anemia in this country, both which takes care of both nutritional and non-nutritional component. There are a lot of institutional mechanisms here. I would Kapil Yadav is not here, but what the government of India and with the support of UNICEF have established
So,
a national.
Kapil has just joined.
Okay, so I will just make, I'm just making a point, and Kapil then can carry on. So a National Center for of Excellence in Anemia Research has been established at AIIMS, New Delhi, and Professor Kapil Yadav is leading that exercise, and it is providing technical support as well as research support. We know that at the highest political level, there is support both at Prime Minister, Health Minister, and the CMs have, but dedicated Anemia Mukt Bharat units at national and state levels are still missing, and there is a need to work more so that at state level and at district level these things happen in a smoother manner. This is fortified food distribution through midday meal and ICDS, and it started in 2020. And there is evidence that it reduces anemia among various age groups. And again, coming to a point that this is food fortification is giving nutrients in a more natural way. And we hope as the fortified food is available, rice is available more widely, the impact will be much more visible. And monitoring ones, there is a monitoring framework, but I told you about 6 key performance indicators, and today only 16 states out of 36 are reporting all the key performance indicators, and so this has to be taken up at a much faster level. And there is suboptimal use of dashboard. If you visit AMB website, you find people are really not using it. There is a very nice dashboard. There is need for trans-sectoral working with various departments and sectors, and so that the action is taken on a real-time basis. And there are challenges. There is over-reporting of number of beneficiaries. There are a lot of issues of duplicate entries, incomplete data, the denominators, district-wide information is not very well available. So this whole monitoring evaluation has to be strengthened. It has to become real-time so that action can be taken at the ground level, at district level. And the important point is, the strong point is that it is visible to everybody, and that makes accountability is much easier. And if we start using it better, probably I think we can move much faster. So we need to have, if we really want to have a 360-degree approach for anemia Mukt Bharat, we need to have, while the program is moving, the data availability, and we should understand what are the barriers and facilitators so that they can be taken care of, which helps us to redesign and refine the program if necessary. Just like, as I said, one of the important points is how to reach various population sections, and then improvement in the measurement of prevention, diagnosis, and treatment of anemia. Thank you very much.
Thank you, Dr. Arora sir, for highlighting the 360-degree approach to the monitoring and implementation of the Anemia Mukt Bharat. And it is really a great initiative of government that there is a food fortification system, at least in ICDS and midday meal programs. I want to make a point that not only, like Dr. Arora sir said, that not only it is a natural way of giving iron and folic acid, iron not only preventing from iron deficiency anemia, but even folic acid supplementation will prevent from a lot of neural tube defects also. And once, if in case, like we have made the mandatory, like iodine fortified salts are mandatory. Similarly, if in near future, if you really want to make India an Anemia Mukt Bharat, we have to somewhere down the line we have to make the fortification of iron and folic acid in rice or the wheat flour mandatory over next few years. So thank you, Dr. N.K. Arora sir, for your giving the insight into the program. Now I will hand over again to Dr. Anupam Sachdev sir to put some words and invite Dr. Kapil Yadav.
I'm this in cricket terms, 360-degree approaches being talked about all the time. And I think it also is an important approach in health sciences, and especially in public health, where you need to look at all the angles and all the all around you. Our next speaker is Dr. Kapil Yadav. He is from the Department of Community Medicine, and as Dr. Arora told us, he is in charge of the National Anemia Research Center in All India Institute of Medical Sciences. May I request Dr. Kapil Yadav to please come in?
Thank you so much, sir. Hope I'm visible and audible?
Yes, sir, you
are. Thank you, Anupam sir, and I'm grateful to Indian Academy of Pediatrics for providing this opportunity. At the outside, I'll convey my apologies because there's a internet shutdown in AIIMS. It's in news everywhere. So we are under a ransomware attack. So pardon for if there are any connectivity issues, because we are logged in from our private networks. The AIIMS network is not working. I'll request, can I share the slides, sir?
Yes, sir, please go ahead.
So are the slides visible, sir?
Yes, sir.
Yeah. So it's a very event because we are celebrating World Anemia Day, and I'm grateful to Indian Academy of Pediatrics for giving AIIMS and National Center for Excellence in Advanced Research on Anemia Control, AIIMS New Delhi, an opportunity to present this work. And in fact, we were very heartened to see the recent recommendation that has been published by Indian Academy of Pediatrics focusing on nutritional anemia in children, because anemia in children constitutes to be a very large problem. Unfortunately or unfortunately, AMB program, we have not been able to make much headway or focus on this particular neglected area. And I'm grateful to Ministry of Health and Dr. Ashok Babu sir for supporting us and making AIIMS a technical support unit for this anemia program. So NCRA has a brief journey, and in fact, in pediatric terms, we are still in under 5 age group. We were established in 2018. So it's fourth or fifth year of our existence. And that year we have strived to provide technical support to Government of India for implementing Anemia Mukt Bharat. So as this is the 6x6 strategy that Anemia Mukt Bharat and all of us are familiar. So whatever the available knowledge, the focus in Anemia Mukt Bharat was to have a systems approach to addressing anemia, because we have been talking about anemia since 1972 in India. In various forms, there have been programs, but we have not made much headway. So, we took stock of that, and Ministry of Health and Family Welfare had constituted several technical committees, 4 or 5 technical committees, to come out with these guidelines, which took into the existing evidence and also learned from the earlier programs, both the successes and failures. So one of the 6 institutional mechanisms in the 6x6 strategy was establishing a national center of excellence in advanced research on anemia control. It was decided to have it at AIIMS, and subsequently in next stages, there will be a similar centers at state, which will have a vision to develop and provide technical support to Ministry of Health and Family Welfare, Government of India, for incorporating scientific policy and community perspectives in policy programmatic decision for control of anemia. These were the broad 6 objectives that were identified by the ministry for us. One was technical inputs, including advocacy, research needs, which would include and focus primarily on operational research, program implementation and monitoring evaluation, Apex reference laboratory, and 5th was facilitate capacity building for anemia control, both at center and state level, and mentor and support regional centers. So in brief period of 4 years of our existence, out of which 2, unfortunately, we lost to COVID, we were able to have some success in few of these stated objectives, but there is a lot of work to be done in other areas. And we are glad that an organization and association with a rich legacy and history like IAP is now come forward. And in fact, on 21st of December, we are hosting a consultation on anemia in children in AIIMS, which will be held in jointly with NCRA and PAN Society, which is a subcommittee of IAP. So Indian Public Health Association and Indian Academy of Pediatrics would be hosting that meeting. And we are hopeful that after deliberation of experts in this area, we'll come out with some call of action for pediatric anemia or anemia of children in India. So in capacity building over last few years, we have held several national level TOTs, 3 national level TOTs, and trained around 85 master trainers. Primarily, these belong to AIIMS at state level. And now we are planning to reach out to other institutions. And in fact, before just last week, I had a chance interaction with Professor Jagdish Chandra, and sir suggested that maybe we can have similar TOTs for focusing on anemia in children. So that model can be taken further forward. We have had 4 national level partner meetings, and on this basically focuses on reaching out to all partner agencies, both international development agencies, bilateral development agencies, and Indian non-governmental organizations. Training at state level and AMB plenary sessions. So we have had state level launch of Anemia Mukt Bharat. So NCRA has participated in this training meetings. We also had plenary sessions in various professional associations. And in fact, with PAN Society, we have already had webinars on focusing on research priorities. And I'll appeal to the senior functionaries of IAP who are present today to provide a platform for anemia during the plenaries of annual conferences of IAP, because that's where the maximum reach could be achieved. We have had similar engagement with FOXY also. Test and talk, treat and talk camps has been one of the success stories of our association with Anemia Mukt Bharat, and I'm grateful to Ministry of Health and Family Welfare for providing us a platform at various levels. Now it's not only a camp approach, but it has been incorporated as a key strategy for AMB program itself, and several crores of individuals have been screened using these test and treat camps and provided BCC advocacy. Technical inputs and advocacy, we were part of AMB operational guideline development groups along with several other experts at national level. In terms of guidelines, we have develop guidelines for test and treat intervention, digital hemoglobinometers. That is one of the I think one of the success stories of the AMB program so far, because historically anemia was being primarily diagnosed clinically, but now we have these POCT devices available right across various geographies of India. And I think I'll appeal to IAP to advocate to Ministry of Health and Family Welfare and JS sir, who is there. Currently, the AMB program says that the screening has to be done for adolescent age group and for pregnant mothers. So if it could be extended to under 5 children and school going children, so that would be one seminal contribution from IAP. Ferric carboxymaltose is parenteral iron and IV sucrose. That is one of the intervention that we have done some work in past, and that is now part of the strategy. Iron fortified food was one of the key strategies of AMB, but now it has been taken up by Honorable Prime Minister, and rice fortification, in fact, has been scaled up right across India in a very brief span of 2 to 3 years. At least 1/3 of Indian population would have access to iron fortified food in form of rice. We have a AMB training toolkit, which is available both in e-module as well as in physical format. So it is accessible to all and is available on our AMB dashboard. And in addition to that, we have several publications related to anemia, which includes a periodic update, which is published every quarterly. It is widely disseminated, and we can request IAP to further disseminate it to their targets. We have a TAMES mechanism that is called Research Consortium of ARC, where representation from 7 departments in AIMS, which includes pediatrics, obstetrics and gynae, laboratory medicine, hematology, and now we are expanding it to a few more departments. And I think one of the Dr. Jitendra Meena is being seen, who is a hemato-oncologist in Department of Pediatrics, who's an active participant in our internal team related to anemia. We have the various works that we have carried out in research domain was on validation study of digital hemoglobinometer, various devices, including both invasive and non-invasive digital hemoglobinometers. Non-invasive hemoglobinometers are primarily has an added advantage in pediatric age group, because that is the age group where even the capillary sampling sometimes becomes difficult, especially in a high load setting in OPDs. We have done some work on ferric carboxymaltose, and there are few studies available across globe where FCM is also being seen as a potential substitute for pediatric age group. Also, in fact, I just reviewed one of the remarkable work that was done by a young IAS officer, Dr. Anand Sharma and Dr. Anish Yadav from Karnal district, where they attempted to screen all school-going children using the RBSK platform within a short span of 2 to 3 months, and identified 40 children with severe anemia, and in fact devised a mechanism to transfuse blood in these 40 children. So that is kind of a lot of work is being undergoing in this area. So this blood transfusion, if is not available for all, ferric carboxymaltose could be a substitute for that, for mild and severe anemia cases. Right now it is being used only for pregnant mother, but it can be used in adolescent, and that is anecdotally being used and may have some scope in children. We have done some work in MMS, and I'm grateful Dr. N.K. Rola sir is here. So sir is being spearheading this work. Primarily, this is a research agenda, implementation research mode. We had done a small pilot study, and now with sir's guidance, we are planning to look at generating evidence on MMS use in pregnant mother. And this work, what with sir's input, is now maybe would be of global relevance also, not only for relevance to anemia in India, because anemia is primarily a problem of South Asia, and the solutions would have to be identified by South Asia and primarily Indian scientists. So this is one area that we are working on. MMS might also have some role in adolescent age groups also, but this still needs to be further researched upon. Research work already, Government of India has launched a very, very ambitious and successful rice fortification program. We are in dialogue to undertake a effectiveness, or rather, I would say it is more of a implementation research work that is being rolled out, and we'll plan to do it in one of the states in Assam. We are also partnering to work on exemplar on anemia, because after 4 years of anemia implementation, and there have been certain success stories and there have been misses also. So we want to learn from this 4 year of implementation, that why we have succeeded in few geographies and why we have not done so well in few geographies. So there's a global work, which global group led by Primary Sick Children Hospital in Toronto. They have done some similar work for stunting, and they reached out to us for help on anemia related exemplar work in India. So that is what we are planning to do with help of INCLIN, and IFPRI would also be participating, and obviously Government of India and UNICEF. One of the key, that is, this one is the closest to my heart, and upfront I will confess that I have not been able to do much work on this area and not been much headway, that is developing state center for excellence. So because this was one of our mandate, we very well realize that AIMS alone would not be able to cater to whole of North India, let alone whole of India. So similar structures were envisaged to be supported at state level, and I am through the ages of IAP, I am appealing to all my colleagues from pediatric discipline, if they would come forward and share this responsibility and state level and establish similar structure at state, where the primary mandate would be to help the program reach its logical conclusion. So we need champions of AMB both at state and regional level. So that is what we are looking forward to. So this is a brief plan for NCRA for next 4 years: capacity building, convening and high level advocacy, state level meetings, and technical inputs and research. One of the big agenda for us in R&D is non-invasive digital hemoglobin meters. I'm a firm belief in this day and time when we can put when thinking of putting a man on Mars, there should be solution in science which will enable us to test hemoglobin without undertaking any invasive method, because this will also have a significant benefit in terms of not having any consumable cost, because once we are trying to screen the whole population, so the challenge before us is the cost, not only cost, but establishing a supply chain for consumables. So if we are able to devise some non-invasive digital hemoglobinometer, that will be taken care of. There are some promising devices that are available, and a lot of various groups are working in that, but I'll appeal to my researcher colleagues from pediatric fraternity if they'll come forward and help us in devising this device. POCT for hemoglobinopathy is another area, because now we have nutritional anemia is only one segment of one pillar of anemia problem. You have anemia of inflammation, infection, anemia because of genetic causes. So for that also we need point of care diagnostic device which can tell us that this is because of this particular cause, and remedial action can be undertaken. So POCT for hemoglobinopathies, we have done some work. In fact, a PhD dissertation is going on, and initial results are very exciting. So if that can be also scaled up, especially for patient with thalassemia, with sickle cell disease, which primarily are seen by my pediatrician colleague in OPD. So this would be a game changer for us. FCM and FDM, we need still, it's in a research mode. It needs to be scaled up and implemented in program mode, because it has an added advantage of only being single shot intervention. The current parental formulation requires at least 4 or 5 visits by the individual to health system. So beside cost, it also has an implication of crowding the health system. So FCM and FDM are biologically exactly similar to our existing other IV formulation, but may have an added advantage of giving once only. So if that can be somehow instituted, it will also be a remarkable for us. Food fortification, already a lot of work has been done. So, but if we can advocate it and take the Government of India's agenda forward and ensure its success, there are some other vehicle, flour, salt, which can also be explored. Milk is what personally I am very passionate about. Milk as a vehicle for not only for fortification, but as a source of protein and even energy for children of India, because that is the only vehicle where they will get some sort of, it's a sort of ideal protein. So that can be further worked upon if it can be identified as a vehicle for iron. There are a few success stories from Chile and small studies from Brazil. We are in touch, NCR is in touch with National Dairy Research Institute in Karnal to take forward this work. That's it from my side, sir. Thank you.
Thank you very much, Dr. Kapil, for an excellent review of whatever activities have happened in the last 4 years in the NCAR, and we hope that we are able to get more and more collaboration of the Indian Academy of Pediatrics with the NCAR, and I'm sure it will, both of the organizations will make a dent in the awareness and decrease in the iron deficiency anemia in our country. Dr. Mukesh,
Sir,
are you
I
there?
hope. Yeah, I'm there. I'm here. Sir. On behalf, thank you, sir. Thank you, Dr. Kapil. On behalf of Indian Academy of Pediatrics, it is my humble duty to thank all the esteemed speakers, the faculty for today. And I will especially thank Dr. Ashok Babu, Joint Secretary, Ministry of Health and Family Welfare, for sparing the time. He was present throughout the sessions, despite being busy schedule. That shows his dedication and sincerity towards implementation of Anemia Mukt Bharat. And proud of you, sir, Dr. Ashok Babu. Thank you so much. Thank you, Dr. Narendra Arora. Thank you, Dr. Kapil Yadav. And last but not least, Dr. Anupam Sadev, sir. Very, thank you. And it would have not been possible without your guidance and support. So I thank all the speakers and also thank all the delegates who have joined today to listen and attend this session on Anemia Mukt Bharat. Dr. Pankaj, are you there?
Yeah, I am there, Mukesh. So it was great listening to all the stalwarts in the field of Anemia Mukt Bharat. And as I said, I wish we have more people, but we look forward to this meeting in a bigger physical format at some point of time, in which all these deliberations and maybe more clinical deliberations can be done for the benefit of all the members. So thank you so much, Dr. Mukesh, for taking it forward, and definitely we all got benefit from these talks. So with these
Thank you very
words, I'd like to, yeah, Dr. Nupyum, you want to say something, sir?
Yeah, I just wanted to personally thank all these great friends of mine, Dr. N.K. Arora, Dr. Ashok Babu, and Dr. Mukesh Yadav. It's a personal thank you to all of you for being here with us and, enlightening us on various aspects of Anemia Mukt Bharat and iron deficiency anemia. Thank you.
Thank you, sir. Thank you,
Right.
everybody. Thank you.
So,
Thank you. Thank you.
Thank you.
yeah, we'll see you again some other time, some other topic. Bye bye.
Thank you, sir.